We wrap up Disc 1 of ACCEL with a discussion Roger Blumenthal had with Dr. Blase Carabello, professor of medicine at Baylor College of Medicine in Houston, Texas, on how to choose patients for TAVR versus open AVR.
Welcome, Blase.
Always a pleasure to be on ACCEL.
Blase, tell us a little bit about the background and the randomized studies we have from the Partners trial, and maybe that'll set the stage for what you become an expert in, namely aortic valve replacement versus the transaortic valve.
Thank you. The Partner trial is important for two reasons at least. One, in the whole realm of valvular heart disease, we have very few randomized trials. About 500,000 patients have been randomized for coronary disease and heart failure. 100th of that have been randomized to various trials for valvular heart disease. So this large, well-done randomized trial gave us the kind of evidence-based medicine that we seek in 2012. Number one, and number two, it reiterated how fatal symptomatic aortic stenosis still is in 2012 while giving us a brand new remedy for patients that were inoperable, a very exciting outcome.
Blase, you're a master clinician. What advice do you give to people to help them decide when their patient needs to confront the idea of either aortic valve surgery versus TAVR?
I think certainly for TAVR, as it is being used in this country today, is for symptomatic patients with aortic stenosis who have been deemed inoperable by competent cardiac surgeons. And so that patient, we know once he or she develops the symptoms of aortic stenosis, begin to die at the rate of 2% per month. Very few diseases in all of medicine with that kind of fatality. And so that if the patient wishes or expects a reasonable quality of life, but is disabled or nearly disabled by symptomatic aortic stenosis, then TAVR represents a terrific opportunity. For the patient who is less ill, somebody who may have only minimal symptoms or who may think they're asymptomatic, their physician hears a heart murmur, they're sent to the echo lab, which detects severe aortic stenosis. In those patients, I invariably recommend a standard exercise test. We all know that exercising the patient with symptomatic aortic stenosis is virtually malpractice, has a very high complication rate. But for the patient who says that he or she is asymptomatic, they're going to exercise anyway. And my view has been that it's better to observe an episode of exercise in your office or in the hospital where the setting is safe than to have them exercising out in the woods somewhere. And the data support that concept.
Great point. Now we have one choice, I guess it's the Edwards sapien valve that I guess at Baylor at the VA,
yes,
you can refer patients for that. Tell us what the indication is for the sapien valve.
The Edwards sapien valve is indicated for implantation from the femoral approach in symptomatic patients with severe aortic stenosis who have been deemed to be inoperable. It doesn't quite stop there. We screen about 7 patients for every one that is acceptable. And some of the patients that are not acceptable are so sick from other problems that even if you replace their aortic valve successfully, you would not expect to improve the quality of their lives. And that's, after all, what we're in business for. The average age of these folks are in their 80s. There's no attempt to confer immortality on the patient. The hope is to give them a few years of meaningful, high-quality life at a very acceptable risk. And if they're so sick from lung disease or kidney disease or often liver disease, then proceeding with a transcutaneous valve really doesn't make much sense.
So the core valve, I guess, is the other alternative that's still in clinical trials. Maybe you could give us an overview of the large clinical trial going on with that.
Yeah, so the core valve has its own trial that is near completion. One arm was, once the data from Partner became available, it instantly became unethical to randomize patients to medical therapy. It was equivalent to randomizing people to death. which is not acceptable, obviously. So in that sort of arm of the trial, inoperable patients will be compared to data from partners and from historic data telling us what happens to inoperable patients. The other arm is a high-risk trial where, as in partner, patients will be randomized to either receive a percutaneous core valve or be randomized to undergo standard aortic valve replacement.
So in my olden days, I was in the catheterization lab and doing PCI. I remember the largest sheath I used was an 8 French sheath. Tell us, how big are the sheaths you need now for the core valve procedure?
So core valve goes in through an 18 French sheath. The Edwards valve, a smaller sheath, is available in Europe and will be available, I suspect, here at some point, but right now goes through a much larger sheath, either a 24 or a 28 French sheath, obviously very large delivery apparatus.
Tell us a little bit about the Partners 2 trial and what should we expect?
Partners 2, in its cousin in the core valve, which is TAVR being conducted in Europe, is to randomize patients now at lower risk for a standard aortic valve replacement. I don't think there's any way to predict the outcome of those trials. Once you get down to a 75-year-old patient without comorbidities, the operative risk is only 1 or 2%. Those trials will be in higher risk patients than that, but yet lower risk than the roughly expected 8 or 10% from the current trials.
So in Partners 2, would it be something like a 5%?
I'm suspecting that's right, yes.
What should a clinician do with their 80-year-old patient who says, "Doc, I really don't want to have surgery, but I would consider a percutaneous approach"? How do you try to convey to them what the drawbacks of the percutaneous approach might be in terms of increased stroke?
All we can do is inform our patient. No patient in his or her right mind really wants surgery. I mean, that's a fact of life. And given what seems to be an easier way out, they're going to take it. As you point out, it's one of the things that have driven percutaneous coronary intervention. There's really no data that suggests it saves more lives than good bypass surgery, but it's easier on the patient. It's what patients choose. So for that patient that you describe, the patient who really doesn't want to undergo valve surgery, I think it's important to educate them that this is not the moonshot it was 30 years ago, that the operative risk in good hands is minimal, that the postoperative outcome and morbidity can be extremely low, and to point out that there, at least in Partners A, there was a higher stroke risk for the implantation of the percutaneous valve than for standard surgery. After all, you're taking this fairly bulky device and moving it up through the aortic arch across the carotid arteries, and it's not surprising that you could dislodge debris that would embolize and cause a stroke. I suspect that this is temporary, that as both devices or all devices become more advanced in their engineering and smaller, miniaturized in their delivery, the stroke risk will go down. So it's one of those things that we as clinicians trying to advise our patients what to do, it's going to be a moving target on a very rapidly changing database. We'll have to keep abreast of it.
Blase, as we wind up, what do we know about the durability of the TAVR procedure in Europe and other countries? What's the longest follow-up that we have?
So as you point out, in Europe, there have been over 50,000 percutaneous devices deployed, many of them in octogenarians. So if you were 80 years old and had nothing else wrong with you, you'd only be expected to live another 5 to 6 years. Doesn't give you a very long time to see the durability of a valve. But the good news is there's no signal yet. There is no evidence of early deterioration of the valves that have been put in somewhat younger patients. We know from years of experience that the younger age at which you implant a bioprosthetic valve, the sooner it deteriorates. And we don't know if that'll be true for these percutaneous devices, but at this point there's no reason not to suspect that it might be true. So if history repeats itself, then durability will be related to the age at implant. But we'll have to see. The valves are different. Their hemodynamic properties are excellent because there are no struts. And so the cage is sort of on the outside of the valve. And so the hemodynamics are really excellent, and that may have an effect on actually extending durability. On the other hand, the valve has to be collapsed before it can be implanted. It obviously has to go up the iliac artery. And so that could, depending on how you think, possibly reduce durability. When we know about durability, there's only one way to find out, and that's the weight and see how durable they are.
Blase, final question. Is there a difference in the incidence of the need for pacemaker placement between the sapien valve and the core valve?
Yes, the data are fairly robust that the core valve requires a pacemaker in about 20 to 25% of patients, the sapien valve more like 5%, and that has to do with the different designs of the valve, the core valve being longer in nature and possibly putting more radial stress on the conducting system. I'm not sure we actually know why the risk of a pacemaker is higher. I guarantee you that as you and I are chatting here, there are engineers at Medtronic working very hard to solve that problem.
Well, we look forward to progress in the field, and thank you very much for being with us at ACCEL.
Thanks.
That concludes Disc 1 of ACCEL. For details about studies discussed, refer to the written summary that is included as a PDF file on Disc 3. Disc 2 begins with a discussion on freedom, cost-effectiveness of PCI plus drug-eluting stents versus CABG for multivessel disease in a diabetic population.